catechol methyltransferase inhibitors, or COMT inhibitors. There are 2 on the market, although we only use one. This is the first one, the entacapone, COM10, which is used generally with each dose of your levodopa, and it also inhibits the metabolism of L-dopa, and thus keeps more dopamine around longer. Tasmar is an agent that has been around for a long time, but is rarely used because of some of the side effects that have been associated with it, require certain monitoring. There will be a new COMT inhibitor, hopefully in the next 18 months. This is a once daily COMT inhibitor, opicapone, which is presently under review by the FDA. The last category of maintenance treatments include the amantadine drugs. We have immediate release amantadine, and then we have 2 extended release amantadines, Gilcorbi and Osmolex ER, both of which are taken in a once daily fashion. So these are generally utilized for dyskinesias, the extra movements that can occur in association with the disease, and the treatment with L-dopa or levodopa. All right, in addition to the maintenance treatments, we have 2 what we call on-demand treatments. So many of you know that as the disease progresses, the effects of levodopa change. It's not that the levodopa is no longer effective, but the duration of action becomes shorter, and so we have times when medicines wear off, and then we are waiting until the next dose kicks in. And so for these times, we have 2 drugs that are approved, both Apokyn, which is a auto-injector pen that gives apomorphine and induces the patient to go back on, so the medicine starts working to bridge those times. And very recently, we've had the approval of the inhaled form of levodopa, which would also be used for these down times, off periods that happen as the disease progresses. And so this levodopa inhaled form is not yet available, but should be available in April. So I'd like to talk about some other types of devices that are utilized in the treatment of Parkinson's disease. Many of you who are either Dr. Alvarez or my patients have worn what we call the Parkinson watch, or PKG. It has recently been reviewed by the FDA and is not yet available by prescription, but available at certain centers, including ours. The Parkinson watch is like the Fitbit, if you will, but made for Parkinson's. And so if you're taking levodopa, we might ask you to wear the watch in order for us to track how your day is over the course of 7 days. Many of you often say, well, he doesn't do that well when he's at home. He just performs for you in the office. And so, whereas I would love to spend the week with you at your house, this is the next best way of us having a window of how the patient is over a week's time. So you'll wear the watch 24 hours a day for 7 days, even in the shower while sleeping, and it tracks tremor, tracks slowness, and for those patients that have dyskinesias, tracks dyskinesias. And so then the company will send us that information, and we'll be able to review it at your next visit. And so many of you have done this already, and some of you may ask about it at your next visit if we haven't brought that up already. So in addition to medications, walkers are an essential element of treatment. And I know I have this discussion oftentimes because vanity comes into play and patients don't want to use the walker. They'll leave it at home, they'll say they have it, they don't bring it to the office, and we can't figure out, well, why not? And it's this vanity factor of not wanting to appear dependent. But remember what I said earlier of the goals of treatment. The goals of treatment are to keep you independent. And so if you increase your risk of falling and fracturing your hip or your leg, now you've become completely dependent. And so you need to see the walker as a means towards maintenance of independence and not a sign of dependence, because falling will be the end to independence. And so please look to these implements that we may prescribe for you as a means towards maintaining your independence. All right, outside of pills, sometimes we'll use injections, and these include various Botox-like drugs, because people know Botox, but we'll use Myoblock, Thiamine, Dysport, but predominantly Myoblock and Botox in treatment of two specific problems. One is muscle spasm, called dystonia, which Dr. Lin commented on before. That will relax the overactive muscle. And the other is drooling. So when we inject the cheek with Myoblock or Botox, we can reduce the production of saliva and thus reduce the amount of drooling that occurs. And so it's an important adjunct to the treatment in Parkinson's disease. There are two other classes of drugs that I'd like to comment on for specific non-motor problems. These include hallucinations. This is when you're fully awake, seeing things that aren't there, rarely hearing things that aren't there. And oftentimes these are not bothersome to a patient, but sometimes they produce fear or potential injury because the patient is responding to them or doesn't believe the caretaker when they tell them that that visualized object is not there. And so we may treat it with a medicine called Nuplacid, which is approved for the problem in Parkinson's disease. We may use other medications as well, including Seroquel and Clozaril. For patients who get dizzy upon standing and nearly faint, we may use agents such as Northera to reduce the occurrence of the blood pressure dropping when the individual stands, just leading to dizziness and potentially fainting. All right. So the top of the pyramid is surgery. So we talked about diet, exercise, medication, certain devices, and then in some instances we need surgery to help produce the best effect. And there are two main types of surgical interventions that we'll utilize: deep brain stimulation and the continuous infusion of levodopa into the first part of the intestine where it is absorbed. So there are a number of different companies that provide the deep brain stimulation devices. This includes Medtronic with Activa, St. Jude with Infinity, Abbott, St. Jude with Infinity, and Verisize with Boston Scientific. So all three are deep brain stimulation. They have various differences in the device we use to program, some differences in the ability to program, but overall all are providing deep brain stimulation. And so you may see that your doctor may suggest these interventions for you with certain problems. Two main problems are tremor that doesn't respond to drug, and the ups and downs that I talked about that the medicine kicks in, wears off, or the extra movements, the dyskinesias. Those areas are the most amenable to intervention. And remember, you're not going to do better than the best you do on levodopa when the DBS is there. So the goal is to keep you the best that you are when levodopa is working more throughout the day with those interventions. The last surgical intervention is the continuous infusion, Duopa. This is marketed by AbbVie out of Chicago, and so this is the administration of levodopa directly into the intestine where it is absorbed, so you bypass the stomach and the slowed motility of the stomach, the interference with food in the stomach. Although it does produce a good effect, improving off time, improving on time, I should say, lessening off time by 4 hours, which in general is better than any of the medications, but oftentimes patients will have complications from the device itself, either infection at the insertion site, or the tube falls out, or other problems that have made this intervention perhaps less desirable than DBS. And I don't know, I'll ask Dr. Alvarez perhaps to give me her impression on the duodenal infusions versus the DBS.
I always tell my patients or anyone that whenever there's more than one option for my patients, I think that's a win-win for patients and for physicians. I think the more options we have, the better it is. However, each medication comes with potential side effect or risk. So my take on continuous levodopa is, I think when you look at the pathophysiology and the mechanism of action of the medication, it's very, very good. But you still have this external device that can interfere with your mobility. Patients find sometimes that they feel like they're tagging the tube. The medications can have a problem too, such as the medications get clogged, so its delivery can be affected. But it's an option for a patient. It's just that I have more personal experience using deep brain stimulation surgery for that reason.
Okay, so we're at our next question answer time frame, so please raise your hand. And we have lots of saved questions. We have somebody with a microphone over there, maybe?
Yes, here we are.
Okay.
Going back to the Botox, what about Botox inside the bladder?
Right, so it's, the question is, what about using Botox for bladder problems? And so Botox is approved for use for certain kind of urinary dysfunction, including that which we see in Parkinson's disease. So there are urologists that in the proper settings where Botox could be helpful do offer that as a treatment for frequent urination or other bladder dysfunction. So definitely can be utilized in certain instances. Next question.
I'm athletic and cardiovascular. They're all on back order through pharmacy. What's going on with that?
Yeah, so the question is, what's going on with the fact that Azilect and Levodopa are on back order? And they're actually, this is a, I'm a globalist, but this is an issue of globalization. And so as we expand the availability of healthcare throughout the world, the production versus need is necessarily going to be strained. And so this is an example where the introduction of various treatments worldwide has necessarily strained the production system. And so it's not that those drugs are no longer useful, no longer appropriate, are no longer being produced, but the globalization has affected the availability. The other part is, as drugs move from trade names to generic drugs, the willingness of certain companies to do the equivalent studies, submit them to the FDA, and market factors where companies will fight other companies in court to prevent them from bringing generics to the market, plays into the availability. And so it's a money issue and a globalization issue that's affecting availability of certain drugs. So, next question.
Mary, you're right.
This seems like a pretty good time to ask if there is a central or a best place to go for those of us who just flat cannot afford some of these drugs. Is there a place that offers us financial assistance for people in that circumstance?
Yeah.
I'm not poverty stricken, but
Sure.
I can't afford a $600 a month drug.
Right. So the question is, are there resources for better affording your medications? And so certainly the first part is starting with your insurer. And when your plan comes up for renewal, is investigating, researching it, Just like you compare your auto rates and your homeowner's rates, you should look into your drug coverage. Look into the drugs that you utilize. If you don't get the answers through the paperwork, call the insurer. If you're still employed or belong to the teachers union or other groups that provide your insurance, you need to talk to them, the HR group, to ensure that your needs are being addressed. Because in the broad scope of things, Parkinson's disease is very low on the radar of most insurers and drug providers as when you compare it to lung problems or diabetes or cancer drugs. So they may not be aware of the issue, so you need to make your insurer aware of the issue. The second aspect of your own responsibility is letting your senator and representative know of the problems you're having. And call them, write to them, and inform them so that they understand your situation. Now that may not help you right away, and maybe Tony can speak to some of the more direct sources of assistance.
Like one of the things that he was just covering, when you come time for your insurance to renew, and we've talked about this in some of the support groups, and we will again this year, don't just take the salesman's word for everything because he's trying to get commission, okay? You need to have them, give them a list of the medications that you're taking, make sure they're on the formulary plan, and then you want to know what tier it's under. There are 3 tiers, tier 1, tier 2, tier 3. Tier 1, your copay may be $20. Tier 2, your copay could be hundreds of dollars. Tier 3, you're buying the drug. Your insurance isn't doing anything. So if he can't show you those on there, you don't want the plan. So you want to look at like how much you spend in the year, and that extra $20 or $100 a month for the insurance that you weren't considering may all of a sudden pay for itself if your drugs are on there. The second thing to do is to make sure that you get with the manufacturer. A lot of them now, even with Medicare, if you financially need it, they have patient assistance programs, and they will pick up providing the drug to you at no cost. So you need to look into that. And thirdly, you can also go to our website, and if you're super strict and I mean, we can't do it long term, but if you're like in one small little gap or whatnot, SA Moves is more than happy to try to help you, assist you in any way that we possibly can financially pick something up. It can't be for the long term, but we can get you through that hurdle so you get to the next.
Okay, thank you. Next question, wherever the microphone is.
Yes, on drooling, if you've tried the Botox and different medications and nothing's working, is there something, anything that we can do for drooling?
So back to drooling. So there are, the primary treatment is the injections of botulinum toxin, either Myoblock or Botox. If the injection didn't work, well then the next step would be to increase the dose or modify how much is given in a certain gland. So I wouldn't give up on it only after the first attempt if you do the injection. There are oral medications and drops that can be utilized. Sometimes those are not very well tolerated because they don't just know to go to the salivary glands. They go throughout the body and affect other areas. And then very rarely will we send a patient to have the salivary glands irradiated. So radiation treatment, surgical treatment. Again, while the drooling is certainly a problem, it isn't life-altering in its presence. So we may not want to be that aggressive beyond those 2 initial treatments because of the side effects of radiating that area or surgically intervening. So usually medications and injections are the 2.
Far right, far right.
Far right.
Hi, good morning. Thank you so much. I wanted to have you talk a little bit about contraindicated drugs, such as the HOL drugs. I know there are a lot of us in the room who have had down and out fights with other providers, particularly in hospital and rehab situations. where our loved ones are administered Haldol, Tramadol, and other DOL drugs.
Okay, so the question is, we talked about what drugs we want to use. Are there any drugs that should be avoided? And so there would be two ways of approaching it. One is avoiding it merely because you have the diagnosis of Parkinson's disease. And so those drugs would be any of the drugs that